Hey, what's going on, everybody? It's Dr. Chris here. The week topic here in the office is hip impingement. So let's spend a little bit of time just kind of going over some of the little details of hip impingement. So hip impingement, or the fancy term, is femoroacetabular impingement. So it's just naming where it's at. So the femur being, your leg, the ball of the ball and socket joint. The acetabulum is just the fancy word for the socket of the hip. Okay, so put them together, we have the hip joint. So that's where this impingement is going to occur. FAI is different than the shoulder in that it's more of a bony problem that starts to happen, and then that starts to wreak havoc in the joint itself. Where shoulder impingement could be bony, we could have a lot of that going on. It could be the rotator cuff. It could just be poor stability of the shoulder itself. So that has a little bit more of a leeway as far as what's going to cause it. So for FAI, or hip impingement, we have different classifications that we're going to look at whenever we want to describe this. Okay, so a study done not that long ago where they took 831 surgical cases and they're breaking them down into the different types. So the Cam lesion, C-A-M, Cam, about 58% of the 830 were Cam lesions. And what that is, that's where the bony prominence, or I don't want to call it a bone spur, but a bump, let's say, that starts to form on the head, that's going to happen on the femoral head. So here, it's hard to see probably, but there's some blue. That's where the ball, the femoral head is usually nice and smooth, but now all of a sudden we got this like bump there. So you can imagine as you're rotating the hip in and out that bony bump is going to start to pinch or push into the joint itself. What they're noting is that most of them were young and athletic type males. Okay, and I'll get to that in a second. The Pincer lesion, so this is where the bony overgrowth is happening on the pelvis, or at the acetabulum itself. So you can see there's kind of a green thing poking out here. It's usually more into the front of the joint, which, although this is an amazing drawing, I'm not quite into the 3D realm yet, so I couldn't articulate that. But only about 6% of those cases are pincer, okay? And what they're noting is that they're usually middle-aged females. And then if we look at 35% are mixed, meaning they have both, okay? Now, my experience clinically, or in the clinic and just over the years, I find that females struggle with this the most. And I haven't quite, I've had some in their 20s that have it. I've had some in their 40s, 50s. But I find that females have more of this problem altogether. And I think a lot of that has to do with our pelvis and the way, females' pelvis like to sit a little bit more forward or anterior, and I'll get to that in a second. So when we have hip impingement, so if you're a trainer and you're working with somebody and they're saying, I just have pinching in the front of my hip, my groin hurts, I have groin pain, they might even feel like their groin is tight. Please do not just stretch it. That's not the right solution for this. They might notice snapping or catching. It's just certain movements, it starts to catch, and if they can just kind of like maneuver in and around it, then it feels better. So, these are things to keep an eye on. They might even actually truly feel popping and clicking and things like that. So, when we start to evaluate them, usually we're going to have a lot less hip flexion, so bringing the knee up, and then internal rotation. And you'll know as soon as you start to approximate their hip into that direction, they're either not going to let you do it or it's going to cause pain. And so that's the common way. Now, sometimes we're going to have a loss of abduction and external rotation. So that's more bringing the leg out and the knee out. I find that that's probably more of a labral issue, but they can both happen at the same time. So that's basically what happens. We start moving in ways, I think, that we lose control of our pelvis. Usually this is a core problem. And then the movement of the joint itself becomes sloppy, and then we can start to adapt or create bone there. And then when that starts to happen, we start to impinge, and then the labrum eventually is going to tear. And if these things progress too long, the joint really wears down a lot, and then likely the best option is probably a replacement if that's what we're staring at. Okay, so I find that the best way to address these and to rehab these is to work on core and pelvic control. Because if we anteriorly tilt our pelvis, so that's me like bringing my belt buckle down, so I'm creating more of an arch, that's going to close off the hip joint a little bit, right? And that's why I said more females have that kind of alignment more than men do. And I think that's part of why this happens. I could be totally wrong here, but the point is, when they have it, then we start working on the ability to control, usually the front, the abs, and then working through the glutes and the pelvis to see if they can't neutralize the position. So I might lay somebody on their back, bring their hip up, maybe even challenge it in, and they feel this pinch. Then I'll have them really work on the posterior tilt, engage their core, stabilize, and I'll go through the same motion. And a lot of times that pinch will not be there. And so, it's an easy thing that's, easy to explain but hard to do. Then we essentially have to teach them how to maintain that pelvic alignment through most of their dynamic activities, whether it's squatting, if it's running, golf, all those things. And so, the exercise becomes like the way of life, if you will. So find whatever it is. So I like to start with things on the back, like dead bugs are a really good one to start with this, just to get the pelvic control there, get them to learn how to stabilize pelvis and core, but also move their hip freely. Okay? And then you slowly transition into more weight-bearing stuff, whether that's hands and knees, and then you go to tall kneeling where they're just on their knees, so on and so forth. So just little tips there. You're not going to just stretch or adjust or pull this hip apart and it's going to feel better. I will say when we treat patients with this, there is a lot of reactive tightness, like in the groin muscles and just hip flexors and stuff like that. That can help feel a little better if you can get in there. And then giving them what's called distraction. So anything to help pull the head out of the socket just a bit will give them some relief. But in my opinion, this is all very short term. You're never going to just fix this with treating it. Okay, so always work for the more active approach. So this is hip impingement or femoroacetabular impingement, FAI for short. Little crash course on it. Hope it's helpful. So if you are trainers, you're working with clients, pay attention to this stuff. Us people that are treating patients, we see this a lot. Sometimes we don't even know we're treating it, but we are, because maybe they're only complaining of their lower back, right? So that could be a different topic of a different day. So if you have any questions, let me know. If you have any insights or input, that'd be great. I'd love to hear it. If not, I'll catch you on the next one.